Hi, Marvelous.
In this tutorial, I'll walk you through the sign-up process on NaviHealth. The first step is to enter navihealth.ai into your web browser. Next, click on the sign up button you can find below. Choose from one of the options to register either as a patient, facility, or healthcare provider. Input your details. You can use a registered phone number or email address of choice, but please note that using a registered phone number is compulsory. Make sure to create a strong password. Once you have done that, click on the Finish button to be redirected to input the 6-digit verification code. Get this code sent to your email or your phone number and click to verify the button to complete the sign-up process to get started on NaviHealth. Once the sign-up process is complete, search for a healthcare service close to your location, and once the result pops up, you can search for a facility close to your location. Once you search for a facility, you can click to leave a review on that facility. Make sure your reviews are 100% authentic and original. Input a display name which is not your profile, and thank you for using NaviHealth.
Thank you, everyone. Please let's go to the next slide. Okay, so we are developing our learning management system, which would house courses and the sessions that we provide, and we'll be sending you updates on this once we kick off for you to be able to take courses on the LMS. Please go to the next slide. So we have a quick welcome note from our collaborators, Doctors Foundation for Care. Please go ahead and play this. Thank you very much.
Good day all. Welcome to this webinar, which is our second. On behalf of the Board of Trustees and members of Doctors Collaboration for Care, I welcome you. Doctors Collaboration for Care are a group of Nigerian doctors and healthcare professionals that have left the shores and gone to the diaspora and had specialist training and have now come back together to give back to the healthcare system in Nigeria in collaboration with our colleagues on the ground. Now it's made up of at least 337 doctors and healthcare professionals at the moment, some of who are already in Nigeria and practicing and giving back and collaborating with our colleagues on the ground, and a lot of those that are still abroad still go and give their skills in collaborations with our colleagues in Nigeria for better care of the patient. This webinar is just part of giving back and updating the skills on a very common matter of wheezing, just to make sure people are able to manage it properly. If your other colleagues are not here, please feel free to share the link with them so that they join and all of us benefit. Do have a good meeting, and we hope you stay till the end. There will be ample opportunities for a lot of questions at the end, and there will be an open house. Thank you very much for joining. We're grateful to our partners and collaborators, MDoc and Sub-Saharan Healthcare Solutions, who have kindly come together to help us put the webinar together. Thank you very much.
Thank you so much. Please go to the next slide. Thank you so much to our colleagues from the Doctors Foundation for Care, as well as our colleagues from Sub-Saharan Health Solutions. Please move to the next slide. We will encourage you to follow us on our social media platforms. We are on Facebook, Instagram, X, formerly known as Twitter, YouTube, LinkedIn. Please feel free to follow us so that you get updates on training sessions, you get training materials and information across the different things that we do. Okay, so for part of our our key participation tips. We would ask that everyone, if you can, and if your bandwidth would permit, please put on your videos so that it makes us feel like we're all in the same room learning and exchanging knowledge with one another. We also have mentioned that this session, it's been recorded. The recording will be shared with everyone who is registered for the session. We would also encourage everyone to use the raise hand function if you have a question or if you would like to speak, and as much as the time permits us to, we'll give you room to do so. We will also encourage you to use the chat function. You can drop your questions, your thoughts, your contributions in the chat session as well. We would ask that you respect everyone's opinion. Everyone's opinion is valid, so we will ask that you are please respectful even as you respond to questions or as you respond to thoughts. Whether you have a varying opinion or perspective, please share. We would like to know, but we would like you to share them respectfully. We do have colleagues joining on YouTube as well, so we welcome everyone from YouTube. Feel free to also share your thoughts and your questions on YouTube. We will have team members there who are also extracting this information, and we'll share them live on the session. Okay. If you need any technical support, please put that in the chat. We have team members working behind the scene who will help you. Today's agenda, we have after this introduction, we have a quick pre-quiz where we'd like everyone to attempt to take the questions. There are just 8 of them and they're very straight to the point. The goal is for us to kind of know where we are. And as we go through the session, we improve our knowledge and then we take the quiz again. After that, you would hear from our subject matter experts on the didactic session. And we will go into a quick question and answer session and do a rapid fire session where you can bring as many questions as we can take on internal medicine. Do not restrict yourself to just the topic of the day. Happy to hear questions around the topic of today, especially around different geographies as well as different cohorts. We will also be able to take as many questions as possible. We'll have a panel of seasoned subject matter experts who will be responding, giving their thoughts, insights, and recommendations. Okay, so we'll jump very quickly into the pre-quiz. It will pop up on your screen in a second. Feel free to attempt all questions. There are only 8 questions, and like I said, they are straight to the point, so feel free to take them. If you don't have the question showing on your screen, and if you're using a laptop or a desktop, please go to the bottom of the screen. You would see where you can find polls/quizzes. If you click on there, it will pop up on your screen. If you're using a handheld device, just go to where you have chats, just by your screen, where you have 3 dots. If you click on it, you'll be able to see polls/quizzes, and it will launch on your screen as well. For our colleagues joining via YouTube, we will be dropping a link on the screen so that you can quickly access the questions and answer to the best of your knowledge. Remember, you're not going to be judged by this. This is just for us to be able to understand where we are and track our knowledge gained as we conduct our sessions. I see some answers already coming in. Wonderful. Wonderful. If you are just joining us, welcome. We are currently taking the pre-quiz, so please go ahead and take the quiz. There are 8 simple questions. It's mostly true or false, none of the above. If you feel strongly that's none of the above, please go ahead and tick whatever option you feel is best. Our speaker will do well to also speak to the questions so that if you didn't get any of them in the pre-quiz, you will be informed of the details as he goes through his session. And then hopefully when you take the post-quiz, you're able to pick the right option. So no pressure, no judgment. Like we say, Gen Z say, we listen, we don't judge. In these cases, we take the polls, we don't judge. So please go ahead. Thank you to everyone who has filled out the questions. I see answers coming in. We will give another 3 minutes to conclude the pre-quiz. So please, if you have started, hurry up. And if you are just starting, you're still in good time. Okay, thank you. I see folks still joining. If you're just joining us, welcome, welcome. Great to have you here. We are currently taking the pre-quiz, so please feel free to take the quiz. If it doesn't pop up on your system automatically, just go to the bottom of the screen if you're using a laptop or a desktop. Click on polls/quizzes and it will pop up on your screen. If you're using a handheld device, go to the area where you have your chat function. You will see poll/quiz. And if you click on it, it should come up on your device. It's 8 questions, so make sure you are seeing all 8 and you are attempting all questions. I remember back in school, they say attempt all questions. Even if you don't get the answer correctly now, that's the essence of the entire session. You should get enough knowledge to then get the answers correctly by the time we take the poll quiz. Okay, so we have a minute and a half left. So please hurry up if you've started taking the polls. We want at least 90% of the folks on this call to take the polls. Thank you. Thank you to everyone who has introduced themselves in the chat. I see folks from Abuja. I see folks in Gombe. I see someone says they're struggling to hear. I think it's peculiar to you, Folashade. Do you want to try to maybe increase the volume from your system? And let's see if that helps, because I think everyone else can hear me. And if not, please let us know so that we can get someone to help you. Thank you to those joining from Ghana. I see some of our colleagues from Ghana. Thank you for those joining from Lagos, Cameroon, South Africa. Great to have you here. Thank you. Okay, I think we'll close the quiz in 30 seconds, just to give room for as many as are rounding up. They're just straight to the point questions. Please feel free to respond to all 8 of them. You have to respond to all 8 of them for it to count. So please do finish all the questions. Like I said, you don't have to know all the answers now. The goal is that at the end of the session, whichever ones you weren't sure of or the ones you did not know absolutely, you will get enough information that allows you then be knowledgeable about those questions. And then when we take the poll quiz, the post quiz, you'll be able to pick the right option. Welcome, Hannah. Welcome, Akinyemi Grace. We see you on the call. Happy to have you here again. Okay, please feel free to still share with your colleagues. We're happy to have as many people as can benefit from this session. Please make sure you're sharing with healthcare workers because this is tailored to healthcare professionals. Okay, so we close the quiz in 10, Oh, we've closed it already. Thank you to everyone who responded. I think we will proceed very quickly. Okay, Akinyemi, unfortunately, we closed the quiz. You just joined, so you get a chance to take the post quiz. Don't worry about it. Okay, so next slide, please. We'll go very quickly into introducing our subject matter experts for the day. And we'll start off. Next slide, please. We'll start off with Dr. Adeoye Oluwole. So before I even start the introductions, I'm going to ask for forgiveness in advance. I am an Igbo speaking young lady, so there is a tendency for my mother tongue to affect the pronunciation of names. So please forgive me in advance if I'm calling you like an Igbo, I'm calling a Yoruba name with an Igbo accent. Pardon me in advance. Dr. Adeoye Oluwole earned his MBBS from the University of Ilorin in 2012. He completed his residency training in cardiology and he's obtaining fellowships from both the West African College of Physicians and the National Postgraduate Medical College of Nigeria. He's currently practicing as a general cardiologist, and he has a special interest in heart failure and preventive cardiology. He is married with children, and we're very excited to have him on board today to walk us through this interesting topic. In addition to Dr. Oluwole, we do have some subject matter experts who are in the room that will be part of this session. Like I mentioned earlier, for those who were on the call, we will, at the end of the didactic session, have a rapid fire question and answer session where you can bring in your thoughts, your questions on cases that you have struggled with or cases that you need clarity on. And so I'll go ahead to introduce some of the panelists so that we can run through the process. So we have Dr. Dosunmu Ogumbi. Like I mentioned, sir, I have taken permission in advance and asked for forgiveness. He's a native of Lagos, Nigeria, and he did his medical school training in the University of Lagos. This was before obtaining his postgraduate residency training at University of South Alabama, and then his fellowship at Emory University in Atlanta, Georgia. He's certified by the American Board of Internal Medicine. He also has a master's in health services administration and is a fellow of the American College of Physicians. He was in private practice in the US for more than 20 years before fulfilling a career-long commitment to return to Nigeria to practice here in Nigeria. Accordingly, he's now medical director of Dorchester International Hospital. I'm sure a lot of us here know Dorchester International Hospital, and he is very passionate and committed to contributing to improvement in clinical standards in Nigeria. He is married to Ceci, who is a pediatric gastroenterologist, and they are blessed with 3 adult children. So please, I want to see a round of applause in the chat for our speakers as I introduce them. We do also have another panelist on today's session, and that is Dr. Kunle Fajana. He's a board-certified internal medicine physician with extensive experience in emergency and hospitalist medicine. I hope you can still all hear me. Let me be sure that
Yes,
technology is not being affected. Oh, wonderful. Okay, thank you. He has extensive experience in emergency and hospitalist medicine. He earned his medical degree from the University of Ibadan. That's interesting. University of Ibadan Medical School in Nigeria, and he completed his internal medicine residency at St. Vincent Hospital in Worcester. Dr. Fajana has served as an attending physician in multiple institutions, including Mercy Hospital and Wing Hospital, where he worked in emergency medicine for over a decade. Following this, he transitioned to internal medicine and he was practicing at Whiter Hospital, and now he serves with New England Hospitalists, where he provides care across hospitals and rehabilitation facilities. He has a keen interest in medical informatics, medical history, critical care devices, and laboratory technology. Dr. Fajana remains dedicated to advancing patient care through both clinical and medical innovations. So a round of applause as well in the chat for our specialists, our subject matter experts, like we refer to them. We will kick off, like I mentioned earlier on, with Dr. Luwale's presentation, after which we will take a few questions, and then we will open the rapid fire session. Please feel free to use the chat function. I want you to be able to send your questions, your thoughts. This is a good opportunity for you to get your questions answered, to get clarity with regards to different areas, specifically in the topic, but also other areas of internal medicine. I'm not seeing enough applauses in the chat. I do not want our speakers to get upset and say they will not teach us today. So I want to see as many applauses in the chat so that our speakers know that we are ready to receive the learnings. Okay, over to you, Dr. Luwale. Please go ahead, sir.
All right, thank you very much. Good day, everyone. I hope you can hear me, please.
Yes, we can, sir.
Thank you very much. I believe we are doing good, and I'm delighted to be here, and I want to appreciate the organizers of this program for the opportunity to take this talk. Not all wheezing is asthma. I've been given 20 minutes, and I will keep to that. And I also understand that we have a mixed audience, health workers, doctors, nurses, and as much as possible, I will try and carry everyone along. And like the moderator has said, please, if you have questions or areas that are not clear, please feel free to ask at the end. So I'm Dr. Adeoye, cardiologist, as I've been introduced. Next slide, please. I'll be following this outline. I will introduce what wheezing is, look at what brings about wheezing, and then the various disorders that can present with wheezing. And I will single out one of them, cardiac asthma, because I'm a cardiologist. And then we look at our line of management if you have a patient with wheezing coming to us. Next slide, please. We'll play a short video now that I want all of us to listen, just trying to simulate how wheezing sounds like. Let's listen carefully. I'm sure we can all hear this, the inspiration, and then that expiration, we can hear that musical sound there that indicates wheezing. All right, thank you very much. Next slide, please. Simply put, a wheeze is a continuous coarse whistling sound. A continuous coarse whistling sound. And it's an added sound when we are listening to the breath sound or auscultating the chest during physical examination. I'm sure we are all familiar with the basic breath sounds, vesicular in adults, and then if there is a consolidation or if you are auscultating over the larger airways, we can appreciate bronchial breath sounds. However, apart from these basic breath sounds, we can have added sounds, and one of them is a wheeze. Others include a ronchi, a stridor, a squeak, crepitations, which is called crackles or rails, some climbs and others. So we are looking at a wheeze, and just like I said, simply put, is a continuous coarse whistling sound that is caused by turbulence in narrowed airways. And so the pathology underlying it is that there is airway narrowing. And because of turbulent airflow through the narrowed airway, we can hear a wheeze. And a wheeze can be inspiratory or expiratory wheeze. The common one that we see or we hear in emergency is the expiratory wheeze, especially in patients with acute severe asthma, or they come down with acute decompensation of COPD. However, we can also have inspiratory wheeze, that you are hearing the wheeze at the inspiratory phase, especially for patients who have stridor and they have upper airway obstruction from foreign body. A wheeze, I will also be telling us further when we're examining, can be monophonic or polyphonic, but it's a continuous sound because it lasts more than 250 milliseconds. And the American Thoracic Society described it as an high-pitched sound because the frequency is more than 400 hertz. Like I said, the commonest cause of wheeze in our environment is asthma and COPD. But the thrust of this discussion this afternoon is to let us realize again, for some of us that know before, that all that wheezes is not asthma or COPD. Actually, all that wheezes is obstruction. Next slide, please. This statement, all that wheeze is not asthma or COPD, was actually made by Chevalier Jackson, and he was an American ENT surgeon. He passed on in 1958 and is reputed till date as one of the greatest ENT surgeon of all time. He said that during his lifetime, he actually successfully removed over 2,000 foreign bodies that the patient got, that the patient aspirated both in their airway and in the esophagus, and he was the one that pioneered many of the methods and techniques for removing foreign bodies. And so he discovered that many of these foreign body aspirations were misdiagnosed and treated as asthma because of wheezing. And he was the one that made this famous quote that not all that wheeze is asthma or COPD. Next slide, please. This is the picture of the Dr. Chavele Jackson that I've talked about. Next slide, please. Like I said, the background problem in a patient that is wheezing is because of turbulent airflow through an obstructed airway. I'm sure we're all familiar with the picture on the screen. Just a picture of the airway. We can appreciate the mucosal lining and then the muscular layer and all that. We all remember that in patients that have asthma, the basic problem is bronchoconstriction, which is the narrowing, the contraction of the muscular layer that will now reduce the lumen of the airway. And also in those who have asthma, there will be increased mucosal secretion, which also contributes to airway narrowing. So bronchoconstriction, increased mucosal secretion, or edema all contribute to airway narrowing. Other things that can narrow the airway include external compression. Cases of patients with a pneumothorax, there's a pathologic accumulation of air between the parietal and pleural, parietal and visceral pleura, or a pleural effusion that is compressing the lung tissue from outside. External compression can cause airway narrowing, and also intraluminal obstruction in patients with let's say pulmonary embolism, where there's an embolus that's traveled down and is narrowing the airway. It can also lead to obstruction. So the pathogenesis underlying wheezing is that there is narrowing of the airways, and there is there's turbulent airflow, and the oscillation of the narrowed airway originates and generates the wheezing sound that we hear. Next slide, please. And the disorders that can present as wheezing are varied, from airway disorders, heart conditions, gastrointestinal tract disorders, allergies. Like I said, the common one that we see every now and then is acute asthmatic attack, COPD, which is chronic obstructive pulmonary disease, or foreign body aspiration, bronchitis. Anything that can cause airway obstruction can actually present with wheezing, and including cystic fibrosis, pneumonia, and others. Heart failure is another thing that can cause wheezing, and gastroesophageal reflux disease, Even some medications may contribute to wheezing, and sleep apnea can also contribute. Next slide, please. Here we have a list, an expanded list of disorders that can present with wheezing, and is classified into upper airway obstructions, which can be extrathoracic or intrathoracic, and the lower airway obstructions. It's self-explanatory. UACS means upper airway cough syndrome, which sometimes is known as postnasal drip. And UACS, in conjunction with GERD and asthma, are notorious causes of chronic cough that can actually present with wheeze. And then laryngeal edema, anaphylaxis, obesity, down to asthma, COPD, aspiration, even carcinoid syndrome can all present with wheezing. Next slide, please. Like I said, I would dwell on cardiac asthma a little. I'm sure we might have had this terminology at one time or the other, although generally we are shifting away from using the term because it's confusing. I would like to state that cardiac asthma is not a form and it's not a type of asthma. The normal asthma that we all know is the bronchial asthma, the one associated with chronic inflammation and the intercurrent obstruction and all that. But cardiac asthma is not a type and it's not a form of bronchial asthma. Cardiac asthma refers to episodic wheezing and dyspnea that occurs in patients with left heart failure, despite the fact that they don't have asthma or COPD. And we will still explain how it comes about and what can lead to it. But we want us to appreciate the fact that not all that wheeze is asthma or COPD. And we need to get this right at the point that these patients are coming in, because if someone is having cardiac asthma and we are nebulizing the patient, we are really not helping the patient. Next slide, please. James Hope was the first person to use that term, cardiac asthma, in 1833. And William Osler, the father of medicine, in 1897, described it in one of his articles as follows. He said, in cases of advanced arteriosclerosis, there are often attacks of dyspnea of great intensity, recurring paroxysms, often nocturnal. The patient goes to bed feeling quite well, and in the early morning hours wakes in an attack, which in its abruptness of onset and general features resemble asthma. Two other features about this form of attack will attract your attention. The evident effort in the breathing and the presence of a wheezing in the bronchial tubes and of moist rails, that's crepitations or crackles, at the basis of the lungs. Here we see William Osler trying to describe what we all know as paroxysmal nocturnal dyspnea. And so the term we call cardiac asthma now is we say the patient has paroxysmal nocturnal dyspnea. We really don't call it cardiac asthma, even though they can present with wheezing. Next slide, please. Here is a picture that just shows us the flow of blood. I'm sure we are all familiar with this, but just to explain how cardiac asthma comes about, which we now know as paroxysmal nocturnal dyspnea. The venous blood returns to the right atrium from the superior and inferior vena cava, and from the right atrium to the right ventricle, to the lungs, through the pulmonary artery, where the blood will get oxygenated, and then from the lungs to the left atrium through the pulmonary veins. And normally blood should now flow from the left atrium to the left ventricle, where it is pumped out into the body. What happens, however, is that if there is cardiac dysfunction of any cause, for one reason or the other, the left ventricle is not able to pump effectively. There will be high residual volume after systolic pumping. For example, ejection fraction is supposed to be, let's say, 60%, then it has dropped to 40%, meaning if there is 100 mils of blood at the end of diastole, at the end of systole, we're supposed to have 40 mils remaining, 60% supposed to have been pumped. But now we only have 60 mils remaining, only 40% was pumped because the cardiac function has dropped. And because of that, there will be a backlog of pressure into the left atrium. And unlike that, there will be pulmonary congestion because the lungs will not be able to empty into the left atrium. And that can lead to congestion in the lungs that can make the patient present with wheezing that may be misdiagnosed as asthma. Next slide, please. I've tried to explain these other things that can lead to pulmonary congestion due to cardiac disorder is when there is unusually thickened left ventricular myocardium from uncontrolled systemic hypertension, or patients with aortic stenosis, or patients who have hypertrophic cardiomyopathy. What happens is the relaxation is impaired. And so the left ventricle cannot relax enough to take in enough blood in diastole. And so over time, there is buildup of pressure in the left atrium because there is high filling pressure in the left ventricle. And that leads to left atrial pressure rising up, and then which backlogs to the lungs and then can cause pulmonary congestion and lead to cardiac asthma. If a patient also has mitral stenosis, there will be increased left atrial pressure because blood is not able to empty into the left ventricle. And for patients that also have masses in the left ventricle or left atrium, there can be increased left atrial pressure, which will impair inflow of blood from the lungs through the pulmonary veins and lead to pressure buildup in the lungs, and patient can come down with wheezing. Next slide, please. This is just trying to explain what I've just tried to illustrate what I've explained. Left ventricular dysfunction from any cause will lead to increased left ventricle filling pressure, which will lead to increased left atrial pressure. And then there will be pulmonary congestion. And because of this pulmonary congestion, especially when the patient lies down, because there will be fluid redistribution, the effect of gravity is eliminated. And when you are asleep, even when the dyspnea is building up, you don't get to know in time because you are asleep. Patient wakes up suddenly with breathlessness. And so it's not unusual to see patients being brought to ER in the night or early hours of the morning with breathlessness, and then auscultate, wheezing. We should remember that it may not be an acute asthmatic attack. It may be a paroxysmal nocturnal dyspnea that we also call the cardiac asthma. And if this is not managed well, it can lead to pulmonary hypertension, which can lead eventually to right ventricular failure. Next slide, please. This is just explaining the same process in case of mitral valve stenosis. The same process, it will lead to raised left atrial pressure, which will lead to increased pulmonary pressure and can cause pulmonary congestion and others. Next slide, please. So how do we manage a patient with wheezing? We just try to explain that wheezing talks about the fact that there is an underlying airway obstruction. Yes, the commonest cause, asthma, COPD, but they are not the only causes of wheezing. And if we don't delineate it well at the start, we may end up mismanaging the patient. That would be catastrophic. And so history is very important. And then, of course, physical examination and some investigation, but history is very key. Like I said, if a patient is rushed to the ER the early hours of the morning or in the night, and there's history that he woke up from sleep with breathlessness, then we should think twice before thinking that it is bronchial asthma. Or if we have history of sore throat, we have history of foreign body aspiration or hemoptysis or a fever, it may not be the usual asthma or COPD that is causing these patients with. Next slide, please. Here is a picture of the common 6 P's of things that cause dyspnea. The first one there is bronchial constriction, which we have in bronchial asthma. That's like I said, there will be constriction of the muscles, and then the airways are narrowed. It can give dyspnea, it can give wheezing. But we should also remember that pneumothorax can also compress. External compression can lead to airway obstruction and can also give wheezing. And then pump failure, that refers to heart failure. Like I said, if the ejection fraction drops, there will be high filling pressure, there will be increased left atrial pressure, which will lead to pulmonary congestion, and patient can present with wheezing. Pneumonia also can cause consolidation in the lungs and airway obstruction, turbulent airflow, and can present with bronchial breaths and sometimes with wheezing, crepitations. And then pulmonary embolus, intraluminal obstruction, like I explained the other time, can actually cause airway obstruction and present with wheezing occasionally. And we can have foreign body, in which case we may need to bring in the ENT to remove. It may also be a cause of wheezing. Next slide. And so when we are taking history and we get history that the patient is hypertensive or diabetic, or there has been history of palpitation, chest pain, orthopnea, we should think that it may be a cardiac related pathology. And then history of cigarette smoking or biomass exposure, history of exposure to dust, farming, we raise the suspicion that a COPD might be the likely cause of what we are dealing with. And then if there has been recurrent productive cough, especially purulent sputum, you can be thinking of suppurative lung diseases like bronchiectasis, empyema, lung abscess. If the onset of the symptoms is rapid and we can get history of foreign body aspiration, it may actually be an aspiration that is causing it, or if it is a slowly developing symptom, it can be a tumor that is compressing the airway and is causing the wheeze. And then if a patient has a thyroid surgery or a thyroid scar or a thyroid mass, it will be good to look into the upper airways because obstruction from the vocal cord, paralysis, and others too can lead to wheezing. Next slide, please. After history, we examine the patient following the normal procedure, look out for pallor, cyanosis, any fever, lymph node, pida edema. If a patient is wheezing and there's pida edema, again, you should call our attention to the fact that it may not just be asthma. And if it's asthma or COPD, maybe it's now complicated with right heart failure, just like we explained the other time. But straightforward acute severe asthma will likely not cause pida edema. It's likely to be a left ventricular failure. And on the examination of the chest, we follow our inspection, palpation, percussion, auscultation. All those can give telltale signs as to what is going on with the patient. Maybe there's consolidation, or there's an effusion, or there's collapse, or there's fibrosis, as the case may be. Next slide, please. And then we examine the cardiovascular system too. By the time we see a patient having thickened arterial wall, and is having raised jugular venous pressure, and is having a third heart sound, it's likely there is left ventricular failure in the background. We should also look at the ear, the nose, and the throat, and make sure there are no enlarged tonsils, and the thyroid gland is not enlarged. Of course, basic investigations, full blood count, there is an infective process going on, we'll see it, electrolytes and others, urinalysis. Very importantly, the ECG and the echo. If there is COPD or asthma, especially if it's been there for a long time, we tend to get features that are in keeping with right atrial enlargement, right axis deviation, right ventricular hypertrophy on the ECG. However, if the ECG is now showing LVH and it's showing left atrial enlargement and it's showing extreme left axis deviation, we should think of a cardiac cause. Of course, echo will show us the chambers of the heart, whether they are dilated, the systolic function, whether there is mitral stenosis. It can even measure the filling pressure by surrogate and all that. And that will really help to make up our mind as to the source of this wheezing. And B-type natriuretic peptide is now an intake, at least that is useful in the emergency. Patient comes in with dyspnea, you can quickly assay it by the bedside if available. If the dyspnea is of cardiac origin, it will be elevated. Once a patient is dyspneic and the BNP or N-terminal pro-BNP is less than the cutoff, you can safely assume that it's not of cardiac origin while you continue your evaluation. Generally, a value less than 300 nanogram per liter or picogram per minute rules out acute heart failure as a possible cause of the wheezing in the patient. Next slide, please. And then imaging that we can do X-ray, CT scan, high resolution CT, can also identify for us if there's bronchiectasis or pneumonia, interstitial lung disease. Spirometry is also important to be able to delineate between asthma and COPD sometimes, because it may sometimes be challenging. Of course, we remember that in asthma, the reversibility is complete, but in COPD, they may not have complete reversibility after you've given them the bronchodilator. So spirometry can help us know what exactly and the type of obstructive airway disease the person is having, and even if it is either obstructive or restrictive, as the case may be. Indirect visualization can also be helpful. Laryngoscopy, that flexible or rigid, especially if there is a history of foreign body aspiration. Next slide, please. This is just a picture showing the process of doing laryngoscopy, looking into the airway, bronchoscopy, and then you can look down through the larynx and even down the upper, the lower airways to see what. And then samples can also be taken from masses. Bronchial washout, lavage can be done through a laryngoscope and the bronchoscope that will help us know what exactly is going on. Next slide, please. So for the treatment, of course, we first establish what is wrong with the patient before we can treat the patient. And following the outline steps, history, examination, and then investigation will make up our mind, and that will not determine how we go about it. But first and foremost, we evaluate the patient that is wheezing to determine the severity of respiratory compromise, then the rapidity of the worsening of the case. And so it's an emergency, especially if the SpO2 is down and they see the patient sweating, in respiratory distress. As we are trying to stabilize the patient, we're also trying to take one or two histories so that we know exactly what we do to manage this patient. Next slide, please. This is just a picture showing the nebulization of short-acting beta agonist that we usually do for patients that have asthma, acute severe asthma and all that. Such that the aim is to dilate the airway, and that will improve the airflow, inspiration, expiration, and that will, of course, relieve the wheezing. But like we are trying to say, that it's not all airway wheezing or obstruction that will respond to this, as the case with the other picture is showing a patient that is using the salbutamol inhaler. Next slide, please. And then for patients with impending respiratory failure, we may need to intubate them. And then in the process of intubation, we can also have a look at the upper airways, and the bronchoscopy can be done. And if there's resolution of wheezing with intubation, it suggests that the area of obstruction is actually in the upper airway, and it will be extrathoracic. You remember the earlier classification that upper airway obstructions can either be extrathoracic or intrathoracic, and then the lower airway obstruction. So if the wheeze is relieved by intubation, is suggesting that it's upper airway and it will be extrathoracic. And then for patients that don't need urgent or emergency intubation, we can evaluate and then come to conclusion of what's the diagnosis, and then appropriate referral that to a pulmonologist, cardiologist, ENT surgeon, or any other as need be. Next slide, please. So in summary, just to drive home the point again, not everyone with asthma wheezes. Someone can have asthma and they may not have a wheeze. The underlying problem with wheezing is that there is turbulent airflow through a narrowed airway. So if the airway has not narrowed to a critical point, there may still be laminar flow through it and it's not turbulent, and so there will not be wheezing. So not everyone with asthma wheezes, and not every wheezing patient has asthma, because there are other things that can cause a patient to wheeze. And while asthma and COPD are the common causes, other things can cause it. And then it behoves us to do proper history taking, examine the patient properly, do appropriate investigation, so that we can know what exactly is going on with the patient, and if need be, manage appropriately or refer as the case will be. Thank you very much. I think I've come to the end of this slide. Thank you for listening.
Thank you so much, Dr. Luwale. Please, a round of applause. Thank you so much. We truly appreciate it. I believe that everyone, for as many as were taking notes as he was speaking, thank you, sir. We do have 2 questions that I think we can take now before we go into the rapid fire session. I want us to be able to have enough time to do that as well. So one of the questions says, Are there any emerging biomarkers or novel diagnostic tests that might identify the underlying causes of wheezing?
Oh, thank you very much for the question. I made mention of one of them, at least from the cardiology point of view. That's the BNP, the N-terminal pro-BNP, or there are markers that indicate if there is heart failure. And there are various cutoffs depending on if it's acute heart failure, if it's chronic heart failure, if the patient has atrial fibrillation. And there are things that can also make the BNP to be unusually high or low. But generally speaking, once BNP is less than 300 picogram per mil in a patient with acute onset dyspnea, it's very unlikely that the dyspnea is due to acute heart failure. And so the B-type natriuretic peptide can be of help in the acute setting, at least before we are able to do a chest X-ray or do an echo or do a chest CT and all that. We can quickly make up our mind based on the history and the examination and the result of the BNP, whether this dyspnea and this wheezing is of cardiac origin or not. Thank you.
Thank you so much, sir. I think another question says, in cases where wheezing is present, but asthma or COPD are ruled out, how do you approach the management of these patients?
Again, thank you very much. Proper history will have given it away from the onset. History of the cause, as in what is the causing it, the cause, COURSE, how the patient has fared with the dyspnea, whether it's positional, any chest pain, palpitation, leg swelling. If one is having progressive difficulty in breathing and is coming with this wheezing, and there has been history of weight loss and then history of hoarseness, it's pointing to the fact that there may be something causing obstruction and is affecting the airway, most likely maybe a malignancy somewhere. And so by the time we take the history very well, we'll be able to at least narrow down the differential. Oh, maybe there's an obstruction somewhere, it's been a progressive thing over the year, there's associated weight loss, or maybe the person is a non-hypertensive, doesn't use his or her drugs very well, there's palpitation, there's chest pain, there's a exertional dyspnea, then we are thinking of cardiac, and then all that history that will give it away. Someone is having frequent dry cough, dyspnea is worsening, we can think of interstitial lung disease or suppurative lung disease or any other. So proper history and then proper examination, both general examination, cardiovascular examination, chest examination, will help us to narrow down, and even the abdominal examination, neurologic. And then based on that, we can now do some basic investigation. So the way I will answer the question is just proper history taking, thorough physical examination, and then appropriate investigation. Be able to make up our mind what is responsible for this wheeze, but it's not every wheeze that is due to asthma or COPD.
Thank you so much. We do have some other questions, but I think it would be good to open it up to let's just use that as a good leeway to the rapid fire session. We have our panelists on the call, I believe. So we will just bring up our panelists. I introduced them earlier on. Just to also say that we do have some other subject matter experts who are on the call, and we'll be jumping in from time to time.
All right, so it seems we've lost Adora for a bit. I think she's trying to reconnect. So a marvelous street, if we can just get the panelists on so we spotlight them and we can get into the rapid fire session. All right, I see you have Dr. Ogunbi. Okay, so I think there's still one more person, please. If you could please just quickly do that so we can start.
Jano, please, can you come on your video?
Oh, yes, please, sir. If you could come on, put on your video so we can spotlight you and get started. All right, perfect. Seems like we have everyone here. So we'll go into the rapid fire questions. I will start with the one of the questions we have in the chat. So Kende is asking, and please I'll open it up to any of our doctors to respond, please. Are male children more prone to respiratory diseases? Dr. Ogunbi, would you mind responding to that for us? It seems like you're muted. Oh, okay. Marvelous Estrida, please, you need to help with unmuting so they can speak. Okay, I've just done that. Okay, you should be able to speak now. Thank you.
Hello. Yes.
Yes.
Hope you can hear me.
Okay.
Yes, I'm not aware of any difference between males and females at any age with respect to respiratory disease. Now, I'm not a pediatrician, but I'm not aware of any difference in males and females. That'll be my answer. I don't know if anybody has anything knows differently.
I think I agree with Dr. Gumbi too. Again, I'm not a pediatrician either, but I'm not certain that there's a difference between the two sexes in terms of presentation.
Right.
I'm aware of one thing, when it comes to preterm babies, again, I'm not a neonatologist, but I know that females tend to have better, or males have a higher mortality than females generally for preterm babies, but that's not exactly the same thing as this question. So,
Right,
yeah,
thank you. I see Dr. Ajayi Obe's hand up. Did you want to add to the conversation? I'll just unmute you so you could go ahead.
Yes, just I'm a pediatrician. Yes, males, when it comes to preterm babies, females do better than males. And obviously, chronic lung disease is a problem of prematurity. But in terms of the older children, I don't think there's any difference between the male and female sex in terms of instance.
All right, thank you so much for throwing more light on that. And so the next question is, how does poorly treated URTI result to pneumonia?
Okay, I can make a stab at that as well.
All right, thank you.
Yeah, upper respiratory tract infection per se does not cause pneumonia. If it really is upper respiratory tract infection, it's quite distinct. Now, influenza can predispose to, in particular, staphylococcal pneumonia. That's influenza. Okay, so influenza can predispose to pneumonia. Again, classically staphylococcal pneumonia. And of course, upper respiratory tract infection can also trigger asthma. Okay, but upper respiratory tract infections do not result in pneumonias in general. Like I said, specifically influenza can predispose, of course, can be complicated by pneumonia. And again, upper respiratory tract infections can trigger asthma. So that would be my response.
So typically, most upper respiratory infections are viral in etiology, and should be self-limiting and should resolve within days. However, generally by the time you're having purulent sputum and the symptoms have gone on for over a week, and there's no improvement. So there might be some concern that, maybe now the cause might be bacterial. In which case, if it's also left untreated and goes on for quite a while, potentially, most of there's aspiration in this kind of a person. Maybe somebody with sleep apnea and other upper airway disease. If you're unlucky enough, then maybe you may get pneumonia. But it's probably not a common consequence of an upper respiratory infection.
Yeah.
All right, thank you so much. There's another one in the chat. It says, I think this is from Anita. So how can we objectively differentiate between a panic attack from a more serious cause of difficulties in breathing?
Well, panic attack is more, I would say, is more or less a diagnosis of exclusion in the sense that you'd want to, if you think it might be another cause, a more serious cause, you'd want to focus on that first to make sure, history and physical. Is the person in respiratory distress, use of accessory muscles of respiration, flaring of the early nasa, flaring of the nose or the nostrils, the supracostal or intercostal recession, and use of supraclavicular muscles, is there respiratory distress. If you don't have any of those things, and in particular, if you have tingling or numbness around the mouth, then that could be a panic attack. Panic attack because with panic attack you have hyperventilation and your carbon dioxide level in the blood goes down because you're blowing off carbon dioxide, and as doctors would say, the PCO2 drops. That results in your blood becoming alkaline, and then the skin around your mouth starts to tingle as a result, or your fingers may start to tingle, and that would go along with a panic attack. And then typically there's somebody who has a history of anxiety, look anxious, and may show evidence of something in the history that will make you think of anxiety. Maybe they have maybe insomnia. They get anxious quickly. There are things that will tend to trigger, that will tend to clue you into that. But above all, you make sure that there's nothing objectively that goes along with other serious causes of difficulty breathing. Asthma, wheezing. They're not gonna wheeze. For example, we're talking about wheezing. If somebody is only having a panic attack, they're not going to wheeze. So that might be the simplest thing to state.
All right, thank you so much. Just wanted to say that, so participants, if you would like to ask your questions verbally, do let us know. You can just put your hand up and we will call on you. Just wanted to read another one in the chat that says, is wheezing seasonal? Does it happen only in rainy weather and cold season?
So the answer to this will depend on what the cause is. If the cause is asthma, then the answer would be yes. It may very well be seasonal because asthma can be seasonal, depending on what is triggering it in a particular person. It may be related to changes in temperature, damp weather, or even dust. So if it were to be from asthma, for example, then the answer would be yes. If it would be for another reason, then the answer would be no. Depends on what the cause is.
All right, thank you so much, sir. There's another one. Are there specific red flags in pediatric wheezing that suggest congenital and anatomical, abnormalities rather than asthma? I know Dr. Ajayobe was able to answer the question on the pediatric one. So I don't know if you can come back on and help us with this, but I feel like this is quite similar to the one you had sort of responded to earlier. I'm going to try to spotlight you so that you're able to. All right, ma'am, you should be able to speak now.
All right. Obviously, there are congenital genetic problems, cystic fibrosis, which is rare in Nigeria, rare when it comes to African children. There are other things like the ciliary problems, pulmonary ciliary problems that happen. But these are chronic illnesses. So the things that actually start when they're very young. And usually, also bronchitis is a big problem as well. But these start when they're very young and they are persistent. And actually, in terms of asthma tends to respond to the bronchodilators, whereas most of these conditions will not respond to them.
Thank you so much, Matt. Thank you for clearing that up. Dr. Fajana, did you want to respond, say something as well? I see that you're to just.
No, not at all.
All right. Okay, so I'll go into the next question, which says, what role do imaging and spirometry play in evaluating patients with atypical wheezing symptoms?
Can you ask that one more time, please?
Okay, so it says, what role do imaging and spirometry play in evaluating patients with atypical wheezing symptoms?
Well, I can actually make a stab at that. Spirometry, strictly speaking, spirometry distinguishes between airway obstruction and no airway obstruction. Airway obstruction is caused by, airway obstruction, classically caused by asthma, COPD, and then there are other causes of airway obstruction as well. Sarcoidosis, if it involves, lesions within the airways, bronchiectasis, and and some other less common causes. If you have upper airway obstruction, then a flow volume loop can diagnose that, or imaging, of course. CT scan of the chest may reveal the cause of an upper airway obstruction, for example. Of course, if you do laryngoscopy or bronchoscopy, you can see airway lesions. So, anybody else have any further thoughts? That would be my response to that.
Yeah, so I'd like to go back to Dr. Adeoye's lecture when somebody asks whether there are other biomarkers. And, there's a test called D-dimer, which can be profoundly high, especially in someone that has pulmonary embolus. It's readily available in Nigeria. So that helps in distinguishing whether something like a terrible clot in the lungs as against any other cause of wheeze. Going back to studies, a chest X-ray, as Dr. Gumbi said, it's a starting point, and I think for sarcoidosis, it's pretty classical. If there's a pneumonia or a fusion, you can see it as well. If there's foreign body, especially in the younger age group, if it's bronchial, and if it's it's radio opaque, like a fish bone or chicken bone, or even a metal, you can see that and know where the problem is. If you also are lucky to have, fluid at the base of the lungs, what we call pleural effusion, that can be seen by X-ray too. I think, as Dr. Gumi said as well, a chest CAT scan, if available, is very good in helping to distinguish whether it's upper airway, whether it's pulmonary or cardiac. And, the information can help sort the issues very quickly. If you have the ability to do a chest MRI as well, it's even much more informative. But I think for the future and in our system, even ultrasonography at the bedside can help in, picking up whether what the sound you're hearing is just CHF or somebody has consolidation, from a pneumonia. Even a 2D, 2D, a 2-view echocardiography can help. And no, bedside ultrasound rather, not echocardiography. Sorry about that. If you also have echocardiography available to you at the bedside, that helps also to have whether this problem is strictly pulmonary or strictly cardiac or a mixed bag. Whether there's a left ventricular involvement or a right ventricular involvement, and you can also get an estimate of the ejection fraction from that study as well. Thank you.
Thank you so much. So there's a question in the chat from Bolashade that says, is bronchopneumonia a communicable disease?
Well, pneumonia, whether bronchopneumonia or lobar pneumonia, it's a combination. It is communicable, but it has at least as much to do with the immune status of the host. So, several people exposed to the same organism, not all of them will come down with pneumonia. You have to be exposed to your organism, but the immune status of the host is crucially important. If your immunity is altered in some way, you're much more likely to come down with the pneumonia. And it could be, of course, in adults, it could be things like diabetes or smokers. That could affect the ability of the lungs to properly get rid of secretions and things of that nature. So host factors, those factors that pertain to the patient or to the person, will differentiate between whether one person gets pneumonia or another, typically, in addition to the organism. So it's a combination of factors, I would say.
All right, thank you so much. So it is a combination of factors. Just wanted to prompt everyone as well. If you would like to unmute and speak, please do let us know. Just put your hand up and I will unmute you so you can ask your questions verbally as well. There's another question that says, how does pregnancy psychologically affect the respiratory system? And how can these changes mimic or exacerbate wheezing?
So I'm not OB either, but third trimester, mass below the chest wall, does push on the diaphragm, and that can functionally limit your lung volume, which is also can be a late effect of third trimester pregnancy, especially closer to the due date. And typically that's, exacerbates your GI issues, your reflux, subjective shortness of breath, all from compression of the diaphragm by the baby from below.
Thank you very much.
So
I agree with everything.
If
Go
I
ahead,
may
Dr.
comment,
Gumi.
it's Dr. Adiri, sir. Another thing that can cause difficulty in breathing in the third trimester, apart from what you said, sir, especially in Nigeria, is peripartum cardiomyopathy, which for those of us practicing in Nigeria, we should be aware of, and most time not just the discontinence, the complaints of the person. It's a special form of idiopathic cardiomyopathy. The person doesn't have hypertension or any pre-morbid heart disease and is coming down with features of heart failure late in the pregnancy or early in the postpartum period. And most times, the exertional dyspnea, the leg swelling are usually part of what most pregnant women will have. So sometimes many physicians don't think along that line, and they will just feel, oh, this leg swelling is part of normal pregnancy, you're getting tired is part of normal pregnancy. But if the woman keeps saying that I get tired easily, I get breathless, I think doing an echo, and thankfully echo is safe. Of course, we may not do a chest X-ray, but echo and ECG may help us rule out, and of course, the BMP, just like we've talked about, may help us rule out the presence of peripartum cardiomyopathy, which studies have shown that Nigeria has one of the highest prevalence rates in the world. In fact, in the north, almost 1 in every 100 live births will come down with peripartum cardiomyopathy. So it's something that we should factor in while evaluating pregnant women with dyspnea in Nigeria. Thank you, sir.
And then asthma itself per se behaves differently in pregnancy. We don't completely understand. I think it seems to be related to the fact that the immunological system of pregnant women is different from everybody else. The immune system is altered in a fashion that we don't completely understand. So some women's asthma gets better during pregnancy, others gets worse, which seems to be related to the difference in the immunological status of that woman. So that's another factor as well.
That's quite interesting that it could go both ways, but thank you so much for clarifying, sir. So I will actually be calling on someone. So I see a Bola Shoyombo. Do you want to verbally ask your question? Please, if you could please just unmute the person.
Oh, hello. Good afternoon.
Good afternoon. I didn't want to mess up the medical terms. So.
The question I'd asked was related to EGPA and what the incidence of that was in Nigeria, because of course most of those patients tend to have asthma, and it's how one can, I know it's a rare disease, but is that something that we're seeing in the Nigerian population?
Thank you, Dr. Shambhala, and good to hear from you, my classmate. So very interesting question. I don't know the answer to your question, but it's very interesting because, as we may know, and I don't think this is a violation of privacy because it's publicly known, that was the disease that the late President Yar'Adua suffered from. But it's very rare, and I have not seen it since I came back to Nigeria, where I've been, practicing now for the last 3 years. I have not seen it, but you're right. It is associated with asthma, and maybe we're just not recognizing it as much. But I'm not aware of the incidents, but it obviously occurs, as we know, that famous case. I don't know if anybody else has any insights.
So I've actually lost my connection, my video rather. Can everybody hear me still?
Yes, we can still hear you.
Oh, okay. Yeah, I'm not privy to that information as well, Dr. Maybe Dr. Ajayobi might have any thoughts.
All right, I see if we can quickly get her to share. Dr. Ajayobi, are you able to?
Yeah, I don't have any thoughts on it. No, I don't have any.
All right, thank you so much. Sorry, there's one more question. Given that asthma is a polygenic disease, what do we think the role of genetic editing therapy will be in tackling this disease and potentially finding a cure? Which genes are key?
To be honest, I don't know. I don't know offhand which particular genes, but obviously you have to specifically, test for that. Now, I would imagine that the targets would be those with the most severe types of asthma, particularly those who have high eosinophil levels or high IG levels, and who are particularly responsive to like the monoclonal antibody treatment, for some of these more severe cases of asthma, which we really don't have available in Nigeria right now. And I dare say the gene editing is not available right now either. But again, I would imagine the target would be those with severe asthma with high IgE levels. I think that would be the where you're more likely to have a more fruitful use of gene editing.
All right, thank you so much. So there's one, Dr. Ajayobe, you might be the one to answer this one. So it's, what are the risk factors for micronutrient deficiencies in infants, and what are the dermatological manifestations that prompt suspicion?
Talking about micronutrient studies in Nigeria, there's been a large survey done by USAID and a couple of other people, and they looked into macronutrient deficiencies across the country. But the major ones we were looking at were vitamin A, iodine, and iron. And there have been low levels across the country, but mainly in the north. And it's been related to diet. Micronutrients such as vitamin A has issues when it comes to the eye, it also comes to the skin. You have vitamin C deficiencies and scurvy, and we purpose these things will start to reappear again. And they also have the vitamin B deficiencies, the thiamine deficiency, and all the other things that follow. There's also zinc. Zinc causes acrodermatitis enteropathica, where you have the rash mainly around the anorectal and the mouth as well, to hand, and other things that can come up in terms of skin problems to hand. Just trying to remember, rickets doesn't affect the skin, but also vitamin deficiency. And that's just my take.
All right, thank you so much, ma'am. So we have one more sort of like case study question, and then we'll go into the post quiz. Right. It says just give me one more. Okay. A 43-year-old HIV positive patient with low CD4 counts presents with wheezing and cough. Chest X-ray shows diffuse infiltrates. Could this be PJP rather than asthma?
Well, I mean, I think the simple answer would be yes. I mean, the HIV has a low CD4 count. It could clearly be PJP. I mean, I would be treated for that. Ideally, do a bronchoscopy with a bronchoalveolar lavage and get the diagnosis definitively. But in the absence of that, I would treat empirically for pneumocystis jirovecii. Any other thoughts, my fellow panelists?
Well, I currently practice away from Nigeria, and it's very rare to see somebody with HIV is untreated. So I have not seen that diagnosis in a very long time. You almost have to be homeless and not really care for yourself for the HIV to degenerate into that process. That's been my experience lately. Again, I apologize that I don't have up-to-date information about Nigeria.
I would say it's pretty rare in Nigeria too, because as with PEPFAR program and etc. HIV is treated well in Nigeria as well. Let's pray that doesn't change.
Amen.
Fingers crossed. Thank you so much. Thank you all so much. Thank you to our panelists. Please, if you could please go in the chat and say your thank yous, claps. We've enjoyed from the wealth of experience they've been able to share. Thank you so much. And thank you to our honorary panelists as well, Dr. Ajayi. Thank you for answering some of the questions we had. So we'll go into the post quiz really quickly. Thank you so much. The questions will come up on the screen. If you could please just respond. It's okay. It's fine if you didn't do the very first one. If you didn't take the pre-quiz, that's fine. Please just respond. So you've heard answers to the questions. You've listened to sort of the teaching, didactic teaching very early on. So if you could please just use your knowledge from those to respond to the post-quiz. Just wanted to make sure, DJ, that it is up. I don't see it, but I don't know if anyone else sees the post quiz yet. And then if you have any questions while we're getting the post quiz set up, if you have any questions, you can still post. We'll try to get responses to those. And then if you have any topics you would like us to address in the future, please post those as well. I'm just going to see if I can do the quiz from my end. Okay. All right. And please just let me know if you see it up. Olamide says she doesn't. You should be able to see it come up on your screen now.
It's here now.
Okay, yes. Okay, done. All right, thank you so much. So please do go ahead and respond. I see some responses coming in already. That means people are paying attention. So great. Good to see. And if you, like I mentioned earlier, if you have topics you'd like us to discuss, please do put in the chat as well. We'll take note of those. I will just be quiet for a few seconds so that people can focus on responding. But we're here to support if you're having issues. I just wanted to mention as we continue to fill out the quiz, I see responses coming in, thank you, that if you would like CPD points, we do issue CPD points for this session. Just please do let us know. You can put in the chat so that we can take note. Please just note that terms and conditions apply for being able to get this. If you're unable to see the quiz, just go down to the bottom of your screen where you see the tabs, click on more. You should be able to see polls and quizzes and then click through from there. All right, so I see some people, Olamide says done. So, and I do see quite a number of people filling it out. Thank you for the feedback, Babajide Onokoya. We do appreciate it. If you have any topics you would like us to discuss in the future, please go ahead and put in the chat and we'll take note of those for the next session. I would also like to acknowledge DFC and MDoc, right, for providing this very informative session, as well as Sub-Saharan Health Solutions also supporting to provide the CPD points. So if you do want CPD points, do let us know. We would facilitate that. Okay, so I'll give about a minute more for some additional responses to come in. Okay, thank you for the feedback, Khadija. Okay, so I will do a countdown. All right, 10, 9. Thank you, Oladayo Malomo. Please do fill out the poll, the post quiz. 8, 7, 6, 5. I'm pretty sure this is not how the clock is counting down. This is my pace, so that you can get your responses in as quickly as possible. Thank you so much, Hannah. Thank you so much, Olaoluwa. 5, 4, still waiting on the last few responses. 3, 2, 1. Thank you for sharing your topic. We will note it. Estrida and Marvelous here will note the topic. Thank you for sharing. 1 and 0. I think we're good to close the quiz now, except if anyone who would like a few more seconds. DJ, please just confirm you're able to do that from your end. All right, let's see if I can kind of walk through it. All right, so we have ended the poll, but we'll go through the questions and the responses. Dr. Adeoye, please, I would be requesting that you help with the just explanations for the responses. So the first question says, mechanism of airway obstruction include mucosal edema, external compression, and intraluminal obstruction. Is this true or false, or none of the above?
It's true. The 3 of them listed notorious causes of airway obstruction. Mucosal edema from the inflammation and cytokines. In patients that have asthma can narrow the airway, and then extraluminal compression, like I said, patient with pneumothorax or any other thing compressing the lungs, and then it can also compress the airway. And then intraluminal obstruction for patients that have pulmonary embolism, for example. So the answer is true.
Thank you so much, sir. Question 2 says, cardiac asthma is a form and a subtype of bronchial asthma. Is it true or false?
The answer is false. In the early days of medicine, it's thought that it's cardiac asthma, but from the knowledge of the pathophysiology now, we see that it's strictly not due to obstruction that will come from asthma. Is actually passive pulmonary congestion, just like I explained, from left ventricular failure, extremely thickened left ventricle leading to impaired relaxation, mitral stenosis, or some other causes. So there will be increased feeling pressure of the left ventricle, which will lead to increased left atrial pressure, and then which will lead to congestion, pulmonary congestion in the lungs. And so its own pathophysiology, it's a bit different, and it's not a subtype. In fact, now we call it paroxysmal nocturnal dyspnea, no more called cardiac asthma. So it's not a subtype. The answer is false.
So the answer is false, everyone. Question 3, left ventricular hypertrophy from uncontrolled hypertension, GERD, obesity, and cystic fibrosis can all lead to wheezing. Is this true or false?
The answer is true. The GERD is gastroesophageal reflux disease. It can predispose to microaspirations. And then left ventricular hypertrophy, especially if the wall is very thickened, it can impair relaxation and increase feeling pressure. Obesity and the other cystic fibrosis have all been listed in one way or the other to affect the airway caliber. And so they can cause obstruction, and then the turbulent flow through an obstructed airway can give wheezing. So the answer is true.
Thank you, sir. And question 4, all patients with wheezing should be treated with bronchodilators and supplementary oxygen, true or false?
Of course, the answer is false, just based on our discussion so far. Not all wheezing is asthma or COPD, so we need to pay more attention to the history, physical examination, and then do proper investigation to know what we are dealing with. And so if a patient comes in now with airway obstruction from a foreign body aspiration, and we are nebulizing the patient and we are giving supplemental oxygen, we've not really helped that patient until we do proper investigation, identify the location, and call in the specialist that can help us remove it. So also if a patient has a heart failure and then it comes in with PND and we are nebulizing and giving oxygen, we have really not addressed. So it's not a treatment for all forms of wheezing. So the answer is false.
Thank you, sir. Question 5, absence of wheezing rules out asthma. This is like our topic.
Again, the answer is false. Asthma is a chronic disease, and there is baseline chronic inflammation, and that's why part of their medication, especially the long-term controller inhalers, will contain a steroid. And so that if person is not having wheezing at that time does not mean the person doesn't have asthma. And so absence of wheezing does not rule out asthma.
Thank you, sir. Then question 6 says expiratory flow obstruction that reverses I'll stick that again. Respiratory flow obstruction that reverses with bronchodilators is associated with COPD. Is this true, false?
I will say the answer is false. Wheezing in asthma and COPD is usually expiratory. You know, I said that wheezing can be at the inspiratory phase or at the expiratory phase. The expiratory wheezing is the commonest form that is seen. And inspiratory wheezing is mostly seen when there is foreign body aspiration. But expiratory wheezing is found in those who have COPD or asthma. However, it's known that when reversibility test is done, in asthma, it is completely reversible, at least almost completely reversible, whereas in COPD, it's a partial reversibility. And so that part of completely being reversible makes that question false.
False. This one was tricky for people. It was like we had a mix, almost even number of people going for true and false. Thank you very much for clearing that up, sir. So question 7 says differential diagnosis for wheezing includes aspiration for foreign body, hemostasis, and GERD.
All of them are true. They are all potential causes of wheezing. The hemoptysis is when there is expectoration of blood from the airway, and a lot of things can cause it, most importantly pneumonia or tuberculosis or even lung malignancies. And all this can cause airway obstruction that can cause wheezing. So also the gastroesophageal reflux disease, the GERD, like I've explained. So all the options there are true. they can
Yes,
cause
we've got
wheezing.
this right as well. Thank you so much, sir. And then the last question says pulmonary congestion is associated with a rise in filling pressure, increase in end diastolic volume, and sustained rise in LVDP. True or false?
It's true. If we follow the pathophysiology of paroxysmal nocturnal dyspnea, there is the left ventricle is not able to pump out blood as much as it is receiving. So the end diastolic volume will increase. Also, the end diastolic pressure will increase, not because blood is not getting to the left ventricle, but because of one disease of the ventricle or the other is not able to push the blood out. And so this left atrium that is now pouring blood into the left ventricle, blood will also build up there. So end diastolic volume will increase, end diastolic pressure will increase, then the left atrial pressure will increase, and then it will backlog to the lungs that is bringing the oxygenated blood to the left atrium, and that will lead to pulmonary congestion, and the patient can come down with wheezing. So all those are found in pulmonary congestion due to cardiac dysfunction. So the answer is true.
Thank you so much, sir. Thank you so much for answering all the questions. And thank you to
Thank you
everyone
very
for
much.
participating. Thank you to our panelists as well. Thank you, Dr. Ogumbi. Thank you, Dr. Fajano. Thank you, Dr. Adeoye. We do appreciate it. So we'll go into the reaction survey now. Please let us know how we've done, how you've enjoyed the session. It would come up on your screen just like the poll did. I think it's running now. Yes, so it's launched now. So they're just 4 questions. We just want to know how much you've enjoyed the session. Please do go ahead. We'll give a few seconds to have this done. And then thank you all so much for sharing the topics you would like. I could see some of them coming in as we were going through the polls. So thank you so much for sharing those. Please go ahead and fill out the reaction survey. Thank you so much. And please go ahead and say thank you in the chat. Please let our panelists know that they were appreciated. If you could please just keep the claps coming in.
Thank
We
you
would
very much,
appreciate that.
everyone. It's a pleasure.
Thank you so much, sir. And would like to switch over as we go through that. DJ, we can go on to the next one around our social media links. So please follow us on social media so you're able to get more information on the next session coming in, because we put the flyers and posters out that way. Please also don't forget, if you want CPD points, please do reach out so that we know. Please go ahead and click the follow, like, subscribe. We'll also we put like the sessions from the teleeducation sessions on our YouTube, so you want to check those out so that you can just refresh your memory and just keep the learnings going over and over. Are we done? Sorry, are we done with the reaction survey? Just want to be sure that we've been able to get responses. DJ, please just confirm. Right, thank you so much.
It's still on
Thank
because
you. It's still running. Okay, thank you so much. I think we can go ahead and end it now. Thank you. And thank you everyone for joining. Hope you enjoyed it. It was good to sort of get your questions, and we hope you got responses, the responses you were looking out for. All right. Thank you, thank you, thank you. Thank you, Pekun. Thank you for the feedback. Thank you, Stanley, for the feedback. Thank you, Sheon. Thank you, Aisha.